Next up on primary care, ovarian cancer. It affects white women more, but African American women have a much lower survival rate.
African American women were treated less, meaning they had less chemotherapy, they had less aggressive surgery.
Hello and welcome to Primary Care. I'm your host, Dr. Lonnie Joe. Did you know that ovarian cancer has been called the silent killer? Ovarian cancer is one form of gynecological cancer with extremely vague symptoms which could easily be attributed to other conditions. This explains why only 20% of cases are caught in their early stage when the disease is most curable. Most ovarian cancer cases are diagnosed at advanced stages after the cancer has spread, and in African American women, the disease is often found too late. Research shows that African American women have a lower incidence of ovarian cancer than white women, but their 5-year survival rate is far lower due to the late diagnosis. Joining me today to discuss the treatment and care of African Americans with ovarian cancer is Dr. Michael Hicks. Dr. Hicks is an obstetrician and gynecologist with a subspecialty in gynecologic oncology. He is on the staff at St. Joseph Mercy, Oakland, and St. Mary Livonia Hospitals. Dr. Hicks, welcome to the show.
Thank you, sir, Dr. Joe.
Dr. Hicks, we know that you just got back from Africa on some missionary work that's part of your being and your DNA and what you do, not only all the things that you do here locally. Tell us about the incidence of ovarian cancer on the continent.
Well, on the continent, ovarian cancer is a little bit lower than it is here. Ovarian cancer primarily is a disease that you see in more developed countries. On the continent, you see much more cervical cancer because of lack of screening. Actually, it's the #1 cause of death in sub-Saharan Africa. But here in the United States, ovarian cancer is very common. As a matter of fact, if you see a patient that comes from the diaspora like Africa and moves to the United States, and they're here 10 years, you see the incidence rise in those patients. So it has something to do with being in a developed country like the United States or Europe or Australia. So it's a disease that's unique to the more affluent nations.
Yeah, you know, we saw that early on, 30, 40 years ago, in colonic diseases when people came here from other environments and other countries. After so many years, 18, 20 years, their disease state mimicked that of people who had been here all their life. So I guess we're not surprised that this similar situation exists in ovarian cancer. What about the prevalence of the disease among African American women here in the States?
As you said earlier in the introduction, ovarian cancer incidence is much lower in African American women. However, early stages are lower in African American women. So you see more advanced stages. And you see a high incidence of death rates in African American patients. So it's a disease, although it doesn't affect African Americans as often, it's more detrimental in our community.
How is this disease diagnosed, modern day cutting edge technique right now? How is ovarian cancer diagnosed?
Well, that's the problem, Dr. Joe. Ovarian cancer, that's why we call it the silent killer. It really does not have any modalities of screening. We looked at ultrasound, we looked at pelvic exams, we looked at what women would say, I come in for my pap smear, why didn't they diagnose it? And we looked at blood tests. The problem is we don't have any methodology of early detection. And so therefore, we have to really hone in on signs and symptoms, as you indicated, nausea, abdominal distension, just changes in appetite. So it's a very vague disease, but women have to be in tune with their body.
So those kind of vague symptoms don't necessarily mean they're seen in the gynecologic oncologist's office. This sounds like a symptomatology that is more present in the primary care setting.
You're absolutely right. As a matter of fact, I would say 60, 70% of my referrals come from primary care because the patient will come in with vague symptoms. You know, early satiety, difficulties eating, shortness of breath, abdominal distension, abdominal pain. You know, rarely when I get a patient, it's from the gynecologist, those patients will present with a large abdominal mass. But you're right, the primary care is the person that's going to see these patients often at first, and they need to be aware of these symptomatology.
Does this explain why sometimes the late diagnosis occurs like it does, the vague symptoms that present, the idea in the back of the mind of the provider is not necessarily this might be an ovarian disease?
Well, I think that contributes, but let's not make a mistake here. Ovarian carcinoma, the problem is, by the time a person has symptoms, the disease is pretty advanced. That's the problem here. Unlike other diseases like colon, like breast, like cervix, we don't really have the ability to identify a pre-invasive disorder so that we can basically prevent the progression of cancer.
So basically, we're back to not necessarily screening, but access.
Yes.
In a primary care setting that can actually get ahead of a disease like ovarian cancer.
Well, that's why this show is so important. It's about education, information, exposure, because that's the key. You know, we need to know in our community, well, those things do exist. When we're having some symptomatology, we need to go in and see our primary care. But also the primary care doctor needs to be aware that those symptoms could be related to ovarian cancer.
It's got to be a tough setting to be in to talk about a disease state like this, because the age group of involvement seems to be kind of widespread to some degree, as opposed to some other diseases that we think might be more for the elderly population as opposed to a younger population. But you kind of run the gambit in terms of the age groups that this disease occurs in.
Well, you can have the full gamut. You have different types of ovarian cancer.
Right.
You got germ cell tumors that happen in very young age patients, the teenager. Then you have the epithelial tumors that happen in the later ages. So you're correct. I mean, it's not uncommon to see a young patient. I've had a patient come in, a mother brought her in, she was 14 years of age, she had a large mass in her abdomen, the mother thought she was pregnant. That wasn't the case at all. Here's a young lady that has an ovarian cancer, a germ cell tumor. So again, education is the key. Understanding that these things can happen in our communities. So that's the reason that we're here today, to try to let people know about these processes.
It's all about education.
Amen.
All about education.
100%.
Mike, we're up against a break. Coming up next, you'll meet a woman diagnosed with ovarian and uterine cancer.
Huge cyst coming off my ovarian.
It's been said that knowledge is power. So know that ovarian cancer has warning signs. Some may be subtle, but knowing them gives you more power to find this cancer early, when treatment works best.
Shawn Williams is a mindfulness instructor and a patient of Dr. Hicks. She was diagnosed with both ovarian and uterine cancer over 15 years ago. Thankfully, her cancers were caught early. Here's her story.
My name is Shawn Williams, and I was diagnosed with ovarian and uterine cancer in April of 2003. Prior to my diagnosis, I noticed that my abdomen was getting larger. I did have some pain every once in a while, but I just put that the pain off to, oh, this is what's usual for women and for me. And also I was exercising a lot. Everything was getting smaller except my lower abdomen. And I was at the age where I thought, oh, this is what they call the middle age spread. And then I started noticing that I was becoming a little incontinent, and I thought I was a little too young for that, and also I had not had any children. So I started noticing other things, and I noticed that I had something pressing on me. That's what it felt like, just pressing on me. And when that happened, it was about time for my 12-month gynae appointment anyway. I went to the gynecologist, and when she started to do the exam, she could not get the speculum in. And so she was quite alarmed, as was I. She sent me for an ultrasound that day, and it revealed a very large mass. She then took me into her office and she told me that I want you to see someone. I want you to see Dr. Hicks. I went by myself, and walking into the building, my knees got weak because I was so scared, and I thought, I can't do this. But I did it, and I don't remember a lot of what he said because I was too scared. But I remember when he was leaving, he took both of my hands in his, and he looked directly in my eyes, and he said, "I'm going to take really good care of you." And that really gave me confidence. It calmed me down, and it gave me trust in him. The treatment that I had was a lot of surgery. I had about 8 hours of surgery, and I had a huge cyst coming off my ovarian. That's what tipped me off to there was something really, really wrong. Because my cancer was very early, in a very early stage, I only had to have surgery. So I was very lucky. I'm thankful that I had a gynecologist that knew something was wrong. Primary doctors, I think, misdiagnose ovarian cancer a lot. It's often the signs and symptoms can be gastrointestinal symptoms, and so they send them to, instead of a gynecologist, the primary doctor will send them to their patients to a gastroenterologist, and it gets misdiagnosed until it's in a very late stage, which is very unfortunate. So I would like primary doctors to pay a lot more attention to what's going on. Ovarian and uterine cancers can be caught early, and it's very important to know what the signs and symptoms are. And when you think you have them, even if you think you're bothering your doctor, don't think that. Go find out what's going on.
Dr. Hicks, Mrs. Williams was a patient of yours with both ovarian and uterine cancer who did well. She's now 15 years past diagnosis and treatment and seems to be doing very well. But obviously her disease was caught early.
It was caught early. And she was seen by a primary care physician, and she was persistent with her symptomatology, and she was sent over. Again, she's one of the fortunate patients because even though she had extensive symptomatology, her disease was early, but we had to prove that. So she had an extensive operation to make sure that it hadn't spread anywhere. But we found out that she also had a second primary. She had uterine cancer, which we did not know at the time.
Well, a lot of patients will tell us through routine questioning about their family history, but they invariably leave something out. Did this patient have a family history of either diseases?
She did not, but that doesn't mean that we should belittle it. Family history is very important. 10 to 15% of patients can have a family history of ovarian cancer, so it's very important.
So what are some of the reasons behind the disparities that we see, between African American women and non-African American women as far as both of these diseases are concerned?
Well, I'm so glad you asked that. I was fortunate enough in 2000 to author I think the seminal paper on disparities in ovarian as well as uterine cancer. What we found in that study, and we did, this was completely all 50 states that we looked at. It was a national cancer database study. And what we found is, number one, African American women were treated less, meaning they had less chemotherapy, they had less aggressive surgery, they had less combination therapy, period. The other thing we noted, there was a disconnect in communication. And I attribute that, although we didn't put this in the paper, is that you have to have someone that speaks your language, or someone that understands you from a socioeconomic perspective, or some trust. And so when a person embarks a healthcare system, if there's distrust on both sides, that's going to usually lead to a detrimental outcome. The patients won't get the treatment that they need. They don't know how to advocate for it. And the doctor really doesn't push the issue either. So it was a disaster what we found, but I think it was enlightening. And now what we're seeing now, since we published that people are a lot more aggressive in offering the proper therapy to African American patients.
You know, it's not, that kind of problem list is not exclusive to ovarian or cervical cancer. We saw the same thing right around the same time with the study that came out of Georgetown University in terms of cardiovascular disease and the difference in the treatment that African Americans and non-African Americans received, and also the aggressiveness of it, and also the disconnect in terms of communication. That was very prevalent throughout that entire study, which goes back to the point of patients having a trust factor in people. And that's hard to develop no matter who you are, especially if you got bad news to give.
Absolutely. I mean, look, when we say these things, it's not to point a finger or be disparaging, but it's a fact.
It's a fact.
You know, when we go back and look at the Tuskegee syphilis study, and then we look forward and look at how diseases are taken care of, we look at colon cancer, we look at lung cancer, we look at ovarian cancer. We all across the board have a high incidence of death. And there's a reason for that. And so we have to study that and try to fix that problem. And that's why we're having this communication today, that we want to make sure that we bring light to it, but also bring solutions to the table.
Don't just turn on the lamppost, do something about what you see when the light is turned on.
Absolutely. That's what it's all about.
We're here with Dr. Michael Hicks, and we're going to go to a break. We'll be right back with more primary care.
It's been said that knowledge is power. Knowing what's normal for you and knowing the warning signs of gynecologic cancers. That's powerful, maybe even life-saving. Find out more.
Welcome back. We're here with gynecologic oncologist Dr. Michael Hicks. Mike, talk to us a little bit about the treatment for both of these diseases, ovarian and cervical cancer.
Both ovarian and cervical uterine cancer is going to be staged surgically. So these patients, when they come to the table with a large mass or postmenopausal bleeding, as you would see in uterine cancer, the thing that you're going to have to do is an extensive operation. That means removal of the uterus, cervix, fallopian tubes, ovaries, and the regional lymphatics, the pelvic lymph nodes and the periotic lymph nodes. That's why the surgery is a little bit larger than a regular hysterectomy. But that's the only way we're going to know the extent of the disease, so that we can properly treat patients. That's why, as we talked about in the other segment, many of the women didn't get that operation, so therefore they didn't get the proper treatment. Therefore, that leads to a worse outcome.
So they're not diagnosed early.
Correct.
Possibly not getting the proper treatment.
Correct.
You can expect a worse outcome.
There we go. That is the problem.
You know, a couple of years ago in Los Angeles at our National Association meeting, National Medical Association, we had some extensive discussion back and forth about prevention of cervical cancer, especially focusing on human papillovirus and the treatment, Gardasil. And it was just amazing that some of the recommendations went down as low as young ladies, girls as low as age 9 to receive that treatment. Would you give us an update on where we're at with that approach now?
Well, the original recommendations were starting at 9 years of age up to 26, but they've been extended now.
More than 26?
Yeah, absolutely. They've been extended beyond that. And the thought process is that if you get vaccinated with the quadrivalent virus, then you have the ability to potentially prevent the disease process from pre-invasive disease as well as invasive disease. But the single most important thing about this is you really need to get people vaccinated early, before they have sexual exposure, before they get exposed to human papillomavirus. The Australians have shown that if you institute a vaccination program early, you can really decrease the incidence of cervical cancer as well as pre-invasive disease of the vulva and cervix, because they started doing it nationwide. We're still having some political debate. Should we do this? Is it going to make somebody more promiscuous? That's insane.
How should we be advising these patients in terms of prevention? Is there a set of things that we can direct them to say, listen, if you do these things, you can lessen your risk of exposure, or lessen your chance of getting either of these diseases?
The answer to that is complex, but there are no specific things that you can do to prevent these. And when we talk about ovarian and uterine cancer, we don't have screening, but what we do have is with uterine cancer, and I think this is extremely important in our community. When a woman goes through the change of life, she shouldn't have any more bleeding. There's no such thing as a nuance, the beginning of a new period. So when a person has what we call postmenopausal bleeding, 80% of those patients are going to end up having a malignancy in the uterus. So those patients need to come in. So they need to have knowledge to know you're not supposed to be having bleeding afterwards, or you're not supposed to be having irregular bleedings after 35. And we talked about ovarian cancer symptoms. You shouldn't have a lot of vague symptoms of abdominal pain, distension. They should come in and be evaluated. And the primary care should understand if a woman comes in with postmenopausal bleeding, she should be biopsied. She should be seen by the gynecologist so that she can get ahead of the ball game.
Any role for diet and exercise?
Absolutely.
For most of us, it's a good thing.
Absolutely. General health is important. It's important, and maybe it won't curtail the incidence of cancer, but here's what it will do. When you do have to have surgery or you have your treatment, you certainly do a whole lot better with the treatment. And so healthy living promotes the ability to tolerate any invasion, because surgery is an invasion, or chemotherapy is an invasion, radiation is an invasion of your body. So if you're in the best of health going into it, you certainly will do better.
Better outcomes.
Absolutely.
Any role for clinical trials? African Americans, are last to come to this segment of the research arm, okay? But any role for clinical trials that we should be looking at or promoting in ovarian cancer in particular? Absolutely.
We have several clinical trials, not on the initial phases because we still use the best drugs up front, but we have clinical trials in uterine and ovarian cancer. And those are for patients that maybe have failed first line. The problem is, again, when you look at clinical trials in the United States, African Americans only represent 10% of that population. Again, we go back to access, education, distrust, and it's on both sides. So we need to do better. People that are providing these clinical trials, they have to have more people that promote it in our community and look like us. And we have to be more aware that they exist too.
Right. Most of us would fail trying to bring a message like this in a foreign country.
Absolutely. It wouldn't go forward. And I think that analogy is important because someone that looks like you is always going to be more effective to go into that community and promote that.
Not only would I fail just on the message, the strength of the message alone, I would garner very little trust going
You wouldn't
forward.
have any trust, no credibility, and you would be a failure from the inception. Those are the things that we need to think about. That's why it's critical to have African Americans involved in these initiatives.
And the longer that we wait to correct that in this country keeps us from getting to target, getting to goals in terms of outcomes in disease state. We're in an outcomes-based disease practice state of medicine now, and we're not addressing the things that hinder us from getting to the outcomes.
Dr. Joe, it's simple, isn't it?
It's very simple.
It's very simple. It's not a complex set of circumstances. And so you're right. And until we correct those simple problems, we're going to continue to have the same poor outcomes that we have.
What's coming down the pike? I always like to get into the Star Wars bells and whistles stuff happening. Are we on the verge of getting toward any new treatment in ovarian cancer in particular? Anything in the pipeline?
Well, right now, genetics is where everything is. Everybody's looking at target therapy now. Instead of just using the panacea of chemotherapy that really is not specific, people are now doing genetic analysis of tumors and trying to cone in and identify pathways that are more suited for specific drugs. So that's where the hot and sexy things in cancer is using what we call targeted therapy. But they come with a new set of side effects And so they're not as clean as we think they are, but it's an exciting area of research right now.
Well, we should have learned our lesson with the tamoxifen situation and breast cancer in African American women. Even the National Cancer Institute was apologizing to us because of the way that was handled and the way that the research was conducted also. But now, you got all kind of advertisement on television, on genetics and everything. We should really be embracing this in a scientific manner that says, hey, here's the way or pathway to further treatment or better treatment for a lot of disease states.
Again, this is true. But again, we also know that has to do with education, has to do with access. And it has to do with economics.
Absolutely. So
those things, here we go again.
The same things kind of resurface in all of these conversations.
All the time. But again, if we don't deal with them, we don't change.
Good. Great. We're out of time. We could go on and on, Mike, forever. We've been talking with Dr. Michael Hicks, who is a gynecologic oncologist here in the area at St. Joe's Hospital in Pontiac and St. Mary's Hospital in Livonia. Mike, it's been a treat to have you with us today. Thank you so much. We'll do it again.
My pleasure, Dr.
Excellent.
Joe.
Thank you. Stay right there. We'll be right back with some final thoughts.
It's been said that knowledge is power. Knowing what's normal for you and knowing the warning signs of gynecologic cancers. That's powerful, maybe even life-saving. Find out more.
Final thoughts. Ovarian cancer, a disease state that is typical of how we should be managing and preventing diseases with early detection. This is something that not only affects the patient, but also affects loved ones, family members, and also our community. It is something that we should do a better job in detecting early because treatment is available. For Primary Care, I'm Dr. Lonnie Joe.